بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. I hope that all of you are fine. I'm Dr. Nura Sabah from Kerbala Medical College, and I present to you an important lecture about preterm, pre-labor rupture of membranes. The objectives of this lecture: first, we should know what is the meaning of prom, which is the abbreviation of preterm, pre-labor rupture of membranes. What are the risk factors that may lead to prom? What are the complications that may occur secondary to prom? And the important thing is how we will diagnose a case with prom, and after that we should know the treatment options of those patients. First, what do we mean by prom? It's a condition in which the membranes are ruptured before 37 weeks of pregnancy without an established labor. It complicates about 2% of pregnancies and accounts for nearly 25% of preterm deliveries. In other books, it may reach up to 1/3 of preterm deliveries. Regarding the risk factors for proms, they are nearly similar to that of preterm labor. For example, the main risk factors: patients who have a previous history of prom in her previous pregnancies, if she has genital tract infection in her current pregnancy, if she's a smoker, or if her pregnancy complicated by antepartum hemorrhage. What are the complications that may occur in a patient who has prom? There may be fetal and neonatal complications, and there may be maternal complications, and all of them are important and may be an indication for termination of pregnancy. Regarding fetal complications, it depends on the timing of the rupture of membrane and what gestational age it occur. If it is occur early, for example after 24 weeks, after 5 weeks of gestation, this may lead to oligohydramnios, and if it is severe, it may lead to amniotic bands that may lead to amputation of some limbs. There may be, because of oligohydramnios, maybe lip contracture and pulmonary hypoplasia, and this is an important cause of IUD. Also, if it is occurred early, it may lead to intrauterine growth restriction, and if the condition is not managed properly, it may lead to intrauterine fetal death. Prematurity may complicate prom, either because the patient may enter in spontaneous preterm labor, or because we induce the labor because of any complications that may occur secondary to prom. Sepsis may affect the fetus and even the neonate after delivery. Regarding maternal complications, a very important one, and it is a risky one, which is chorioamnionitis, and the patient may develop postpartum endometriosis. Now, what are the differential diagnoses of a pregnant woman presented to us with a history of watery vaginal discharge? And I want the answer of this question in the next meeting with the good will from you. Now, if the patient came to us and gave us a history of watery vaginal discharge, and we think that this discharge may be amniotic fluid, so we should ask the patient about the duration of this leaking, the amount of the fluid, the color, and if it is associated with vaginal bleeding, or if the patient has a history of previous abnormal vaginal discharge, if the patient has abdominal pain or not. We should ask her about the fetal movement, if she feels any increment in her body temperature. They are very important questions. Regarding examination, First, we should do general examination to the patient, monitoring. We should check her vital signs, and it is very important, the temperature and the pulse rate mainly. Then we should do abdominal examination to the patient to assess the fundal height, checking the fetal heart, and palpate for the presence of uterine contraction or if there is uterine tenderness. Then we can clinically diagnose rupture of membrane by sterile speculum examination when we see the pooling of a fluid in the posterior vaginal fornix. And also by this examination we can assess the cervical dilatation and if there is any cord prolapse, for example, or limb prolapse. Very important points that we should avoid repeated vaginal examination to patients with prom because of the incidence of ascending infection, and this ascending infection may lead to chorioamnionitis or may lead to release of prostaglandins and preterm labor. What are the investigations that will support our finding? Previously, the doctors were used the nitrazine test, which depends on the changes in the pH, and the Ferning test, in which we put the sample of the fluid which is leaking from the vagina on the slide, and we wait for its dryness, and then we examine it under the microscope. There will be crystallization. These two tests are not specific for the diagnosis of preterm labor because they are affected by the urine if present in the vagina, if there is blood, semen, so they are not specific or sensitive. So the researchers were trying to find tests that detect certain particles that are present just in the amniotic fluid. So if these particles are positive in the vagina, so the diagnosis of rupture of membrane will occur. One of these tests is the Amnisure test, which is a rapid immunoassay test, and it is sensitive and very helpful in the diagnosis of rupture of membrane. It detects placental alpha microglobulin 1, which is present just in the amniotic fluid, not present in the cervical, in the cervix or the vagina, or not affected by the urine or blood. The role of ultrasound in patients with rupture of membrane is very important to assess the amount of liquor the patient have or complicated by oligohydramnios. We should know the severity of the oligohydramnios, severe or oligo. Some patients may have anhydramnios, even there is absent of the liquor, and to assess the fetal condition by doing the Doppler study or by physical profile. But we should put in our minds that the sonar is not a method for the diagnosis of prom. Now, if the patient is diagnosed with prom, how we will manage her? First of all patients should be admitted to the hospital for at least 48 to 72 hours. We send her for investigation. CBC is very important to see if the patient has leukocytosis. And because the leukocytosis is one of the physiological changes of pregnancy, so the importance of white BC monitoring is by doing serial CBC. So if there is increment of the white BC count in the subsequent days, that means there is the incidence of infection. We can do for her C-reactive protein, but also it's not specific for the diagnosis of infection and chorioamnionitis by itself. We can take high vaginal swab from the mother at time of sterile speculum examination, and then we can do for her serial high vaginal swabs to screen for the presence of subclinical infection. All women who have prom should have antibiotic routinely, and this prophylactic antibiotic is erythromycin in a dose of 250 mg 4 times daily or 500 mg twice daily, and the patient should continue on it for 10 days, or if the patient starts labor, then she should discontinue it, whichever is coming first. If the patient complete her 10 days, you should stop it, and if within these 10 days the patient start labor, then you will stop the erythromycin. Another important step in the management is the administration of antenatal corticosteroids, and you know the doses and the route of administration from the previous lecture. Tocolysis is contraindicated in patients with prom because the side effect of the drugs may mask the signs and symptoms of prom. So we don't administer tocolysis. If the patient starts to have uterine contraction, we will let her to continue with the labor and deliver her fetus. Also, of the patients with prom, if the rupture of membrane occurs before 32 weeks of gestation, we can give her magnesium sulfate to prevent the risk of cerebral palsy in the premature infant. So, what is the benefit of admission of the patient to the hospital and the monitoring of her is to pick up the early signs of chorioamnionitis, which is a serious complication that may affect the mother, and it may lead to systemic infection. Patients may enter in sepsis and septic shock, and even she may die. And we see many patients that die because either of improper management of the case, or because the patient refused the termination of pregnancy. What are the signs of chorioamnionitis? The patient will have pyrexia, tachycardia, leukocytosis by the CBC, uterine tenderness, and offensive vaginal discharge. The fetal tachycardia, if the baseline more than 160 beat, this is also a sign of chorioamnionitis. So the patient, while she is in the hospital, we should measure her temperature 4 hourly and her pulse rate, and also monitor her fetal heart rate by doing CTG. So the CTG will aid us if there is contraction and if there is abnormal baseline. Also, we should tell the patient, inform her that if she starts to have abdominal pain, if there is changes in the color of the amniotic fluid, to become green, yellow, it's associated with the blood, or if there is bad odor, if she feels fever, an increment in her body temperature, because fever is a medical term. So she should inform us. If the patient during the 48-72 hours don't have any signs of chorioamnionitis and the monitoring of the fetus is good, we should do serial CTG, biophysical profile, and the important thing is the monitoring of the amniotic fluid index and doing umbilical artery Doppler study. If all of our monitoring reveals that the patient don't have signs of chorioamnionitis and the fetal condition is well, we can discharge the patient at home, but we tell her to check her body temperature at least twice daily and to observe any symptoms that occur to her that may be because of the development of chorioamnionitis. So the patient at that time should seek the advice of her obstetrician or come to the hospital. Her follow-up until the end of her pregnancy should be under the supervision of a consultant obstetrician, because now she is a high-risk pregnancy. When we will terminate her pregnancy, if there is no signs of chorioamnionitis and the fetal condition is good, the amount of amniotic fluid is accepted, so she can continue until 37 weeks of gestation, then we terminate her pregnancy by induction of labor. Then we do induction of labor by any method. And if the patient have any obstetrical indication for cesarean section, so we will do for her cesarean section. But if there is signs of chorioamnionitis or the patient, her fetus, become distressed, so at that time we should terminate her pregnancy. And thank you for your listening.